Yes. Good evening, everyone. The topic is prodromal period and the characteristics in psychosis. Prodrome is a Greek word. It's about the onset of something, and there is a mention of the prodromal symptoms. And in psychiatry, in psychosis, we talk about prodromal period, stage, and this is defined as the time period from the first abnormal behaviors to the emergence of first psychotic symptoms. So person is showing signs of pre-psychotic disorders which signal a deviation from their past behaviors, and it becomes meaningful when the final symptoms are emerging, because if a disease has not been developed after the initial period, we cannot talk of a prodromal stage. According to stage, we understand that 80–90% of psychotic patients have changes in their perception, cognition, personality, affect, and behaviors, and yet in 10–20% there is a direct development of the disease. Usually non-specific symptoms and negative symptoms usually develop first, and then come the attenuated positive symptoms. And although majority of schizophrenic cases undergo a prodromal stage, and we don't necessarily or clearly know how many of the patients undergoing prodromal stage are actually developing schizophrenia or other psychotic disorders. Let's take a look at the historical process. Krapalin explained this in 1909, and Bleuler was also providing a concept called latent schizophrenia, which seems to overlap with the prodromal stage, and this is about detecting the first attack and working in a proactive way to prevent the disease. In single-centered studies, they are evolving to multi-centered studies in the present time. There is the Germany European group, and this is the developmental process of schizophrenia. We all know it very well. The premorbid stage is shown in red, and the many factors, including prenatal, play a role here. The prodromal stage, starting at 12–13 years, could last 3 to 5 years, and then there is the onset of the disease when we first categorize. And if we are to see it more clearly here, there is the early developmental period, aka the premorbid period, which is followed by the prodromal period, and there is an untreated period until the first attack, which is until 17–18 years of age. In the premorbid phase, we have developmental, emotional, and cognitive problems. In academic social functions, there are premorbid disorders, latencies in motor development, lack of attention, speech impediment, academic failure, social isolation, and emotional separation. There is the weak premorbid function, and it is related to early phase psychosis onset and also negative symptoms during development of the disease. The subthreshold psychotic symptoms, cognitive shortcomings and negative symptoms, and emotional symptoms and functionality are reduced, and the prodrome can last as long as 5 years. We know that around 1 year before the first clinical contact, these symptoms are starting to cluster. We see here the development of psychosis, and the patient is realizing that something's different about him in one. In the second, the family and the close environment notice this. In the third,
problemi çevresi daha çok görüyor.
In the fourth, the surroundings are noticing the symptoms very clearly, and in 5, the psychosis has clearly started. Between 1 and 2, or 2 and 3, or 2, 3 or 4, sometimes is defined as prodrome by researchers. Here we have negative, positive, predispositive symptoms observable in the prodromal stage. These are not fully psychotic elements, but they are more sub-threshold symptoms. ARMS and prodrome. ARMS is a definition. It's defined as a risky mental condition, and all the individuals who have ARMS will develop prodrome, and we can't normally follow up, detect and follow up the prodrome, but we can define it retrospectively after the disease has started. Prodromal means all the individuals who have it will develop psychosis. It's 100% definite. So the prodrome of schizophrenia is the early or the predictive symptom of this disease. So before the starting of open psychosis, then we can have a good justification for early intervention to protect the patient. Also, there is another concept developed after ARMS, which is ultra-high risk, UHR. So, because of the non-specific structure of ARMS, the concept ultra-high risk was presented in 2003 by the center in Melbourne, Victoria, and this concept was finalized in 2014. So ultra-high risk is a refined extension of the ARMS concept. For psychosis, clinical criteria for detection of high-risk patients. This is what it's about. Again, the researchers are looking into these conditions for defining ultra-high risk. Attenuated psychotic syndromes, the symptoms must last longer than 1 week. Short, limited interval psychotic episode. Brief, limited interval psychotic episode must be shorter than 1 week, and the genetic risk and regression syndrome. All of these three criteria are necessary to call it an ultra-high risk. Here you find more details. Attenuated psychosis symptoms more than 1 week, and so up to 5 years it must be at least 1 week, and the blip must be shorter than 1 week. They should improve by themselves. And here genetic schizotypal personality must be present by itself, and the mental condition and function should have regressed significantly, provided that it's at least for 5 years. And these are some of the more detailed criteria. We find here the fundamental symptom criteria, and you can find this in certain scales as well. Copper, CODIS, the cognitive disorders related to attention, ideation, and these criteria are used for the basic symptoms. The basic positive symptoms in prodromal situations are density of faith, unusual ideation, and they start believing, but they're not fully believing. This is moderate, and severe is believes excessively, the abnormal perceptions, strange noises, and calling of name, or hearing some murmuring sounds, and some shadows on the corner of the eye in the severe stage. Sometimes they might utter some strange words in sometimes they might become unintelligible, and then we will have great difficulty in understanding them. And the basic positive symptoms should start within the last 3 months, and the severity must be accordingly, and it must happen at least once a month, and at least a couple of minutes during the day. This one is the attenuated positive symptom syndrome. We can see one or more increasing symptoms starting last year, and we must see at least one symptom every week. And this one is showing the prodromal states in the genetic states, and there must be a first-degree relative who has a history of any psychotic disorders, and the patient himself should have schizotypal personality disorder, or there must be a deterioration in functionality according to certain criteria. These are the scales like CARMS and COPS used for the continuous risk factors and the states, and if there is a psychotic disorder in himself or a relative, schizotypal personality disorder in himself or a relative, or for the last 1 month, 30% decrease in general functionality index. The difference of COPS is that within the last 1 month or 1 year, there must be 30% decrease in the premorbid, and there must be schizotypal personality disorder in himself or a relative, a first-degree relative. And these are very similar. Some memory assessments, schizotypal assessments, and the MRI scan. This is the Edinburgh schizophrenia high-risk study. This is the North America Prodromal study. We have the Prodromal Symptoms Scale, Prodromal Syndrome Symptoms Structural Review, in structural interview. We have Global Function Assessment, the Prodromal Symptoms Criteria, the Psychotic Symptoms Presence, DSM-4, and CARBS was used, and the list can be longer. Coming to DSM-5, there is a long line of discussions. There's a discussion as to whether to include DSM-5, whether to include APS in DSM-5. So apparently it was included in page 783 in detailed working conditions. Also in page 122 it's listed as other non-organic psychotic disorder under other specific schizophrenia spectrum and other psychotic disorders. Also in our country we don't have it, but in the States the insurance companies can invoice according to this state, but there are some risks. There is not a suggested clear treatment, and this process is not always going to psychosis, and there is a risk of social stigmatization, so it is still controversial. And the ultra-high risk state, looking at the latest studies, earlier detection, increase in an effectiveness of intervention, these are reducing the switching rate, and the rate of switching to psychosis is 30 to 35, and the incidence among general young population is notably higher than the general population because of the specificity of this population. And in 2009 there was a North American study, 377 patients assessed with SIPS, and 40% turned into full psychotic disease in 2.5 years. And from 2002 to 2010, some studies were done in different centers with different numbers of cohorts. And there is a North American NUP study. Normally the rates are below 54%, and usually focusing on 30 to 34%. And we find here is 20% transition, and another one is 90% transition from prodromal stage. Using the Kaplan-Meier method for working data, the estimated transition rate for the first year is 16.6%, and in 10 years it goes as high as 34.5%. So the longer the time, the higher the transition rate. So pre-treatment, ultra-high risk group, we have a lot of biological studies, the new publication every day, and some of them include imaging methods. I did not include many of them. In the prodromal stage, in the risk group, there are two main objectives. First, in this group, to understand whether the characteristics of patients in this group are different from the healthy control group or from the first episode schizophrenic patients, and we understand that they are different and it's more mild. And secondly, looking for a biological characteristic which will make detection easy earlier. This is the second purpose. And in these studies, the volume of hypophysis was studied, and increased volume of hypophysis is associated with higher risk of psychosis transition. In another study, a hippocampus and amygdala volume was studied, and it was insignificant, and it was seen that in first episode schizophrenic patients, left hippocampus volume was reduced, so it was not accepted as a finding for prodromal phase. Similarly, the dysfunction in the deception of visual stimulants were studied, and so it supports the finding that this is not turning into chronic disease. But in another group, a comparison study with a healthy control group, fine motor skills and continuous attention and working memory came with lower performance in the risk group, and we understood in another study that continuous attention function of the risk group was worse than the healthy controls, but it was similar to the first episode psychosis group. Another study was showing that between those who developed psychosis and not, the continuous attention function seemed to be similar. There was no statistical difference, and there was a study in our country by Aydın et al. In 2008 on first episode schizophrenic patients and the risk group using the MRS method for corpus callosum NAA levels, and in both groups the patients had lower NAA levels compared to the control group. Early diagnosis and management of psychotic disorders is important, and so prodromal phase is again important here, and of course this is important for the early detection of relapse and the prospective follow-up of high-risk individuals, and it's also important for prognosis. There was an old trial with 253 patients in the Nordvik Park study. 26% of the patients took longer than 1 year to start an effective treatment, and in 2 years the relapse ratio was higher for those patients whose access to treatment took longer than 1 year. And usually this is this onset of prodromal stage is related to the adolescent years, and in those years the patient is open to many risks, including substance abuse, and it's believed that the environment and the family conditions are also playing a role in this, as suggested by this trial. In secondary protection, until now, the Australian group have started some behavioral treatment models, and the purpose here is to prevent the development of a more severe disease with interventions in the prodromal phase, and so retrospective data collection is used, so this is not very reliable data, and usually criteria like ARMS are used for collecting prospective data. And this is about the effect of cognitive directing psychotherapy on the 9 outcome parameters. And the Manchester group did a 6-month study on the rate of psychosis transition in both 6-month and 12-month periods based on the cognitive treatment, and 3-year follow-up results for this study has shown that in the cognitive therapy group